Good afternoon, everyone, and welcome to today's webinar, The Opioid Epidemic, Organ Donation and Organ Transplantation. We're glad that all of you could join us, and we have a terrific presentation planned for you today. My name is Corey Bryant, and I'm the Communications Manager for the Alliance. Now, we have just a few logistical items to go over before we begin today's program. For those of you who have never joined us before on this webinar platform, the chat feature is located in the bottom left-hand corner. If you have any questions that come up during the webinar, feel free to submit them at any time, and once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, we are recording this webinar, so we will not be opening the phone lines. That means that all questions must be submitted electronically using the chat feature. Registration is currently open for our upcoming Get Connected webinar addressing utilizing elements of behavioral design and improving hospital OPO communication. So be sure to join us for that on May 8th at 2 p.m. Eastern. Registration is currently open for that on our website at organdonationalliance.org. Registration is also open for our next transplant webinar, which is Risks of Coronary Artery Disease Post-Transplant, Myth or Reality. That's coming your way on May 22nd at 3 p.m. Eastern. Again, you can register for all of these webinars and more on our website at organdonationalliance.org. For today's webinar, we are offering 1 CEP-C credit and 1 nursing contact hour courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim continuing education credits. Now, if you're listening in a group, and we know that many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing credits, you have 14 days to claim your CEs. For CEP-Cs, you will have 30 calendar days. So at this point, I would like to introduce our moderator for today's webinar, Andrea Teachin. Andrea is the Director of Transplant Finance and Data for St. Barnabas Medical Center in Livingston, New Jersey. She's also a member of the 2018 Alliance webinar faculty. Andrea, we're glad to have you with us today, and I will go ahead and turn it over to you to introduce our speakers.
Thanks, Corey. Good afternoon, everyone. It is my pleasure to introduce our 2 speakers for this afternoon on this very interesting topic. Our first speaker will be Sharon Sawzak. Sharon is currently the Director of Clinical Services at the New Jersey Sharing Network. In this role, she's responsible for overseeing the Donor Resource Center, the transplant coordinators, as well as surgical recovery and research. She has been a registered nurse for more than 17 years and has been with the Sharing Network since May of 2006. After Sharon, Dr. Samantha Atchison will be joining us. She is a transplant surgeon at St. Barnabas Medical Center in Livingston, New Jersey since 2015. Prior to that, she completed a fellowship at the University of Alabama in Birmingham, as well as a general surgery residency at the University of Kentucky. Sharon, you may begin.
Thank you, Andrea. During the late 1990s, the medical community was reassured by the pharma industry that opioid pain relievers would not cause addiction. Opioids were being prescribed at alarming rates prior to the realization that they were being misused and that opioids were highly addictive. The opioid epidemic has killed 200,000 people in the United States since the year 2000. That is more than 3 times the number of U.S. military deaths during the Vietnam War. In 2016, in the United States, opioid deaths totaled 42,249. That's over 1,000 more Americans who die from breast cancer every year. It also was 5 times higher than 1999. Approximately 40% of these deaths were from prescription opioids, and approximately 37% were from heroin. In the early 1900s, heroin was a legal narcotic, which was commonly prescribed as a powerful analgesic to treat symptoms of acute and severe pain related to surgery, trauma, myocardial infarction, and cancer. In 1923, the Narcotics Division of the U.S. Treasury Department banned heroin as a legal narcotic. The number 1 factor to starting heroin is past misuse of prescription opioids. Nearly all heroin users polled had used at least 1 other drug, and most had used 3 or more other drugs. 3/4 of new heroin users had previously abused prescription opioids. People who are abusing prescription opioids are 40 times as likely to be addicted to heroin. This is far higher when compared to other drugs such as alcohol, marijuana, and cocaine. Heroin, also known as diamorphine, is an opioid known for its euphoric effects. Common side effects include respiratory depression, dry mouth, euphoria, and addiction. Other side effects can include abscesses, infected heart valves, bloodborne infections, constipation, and pneumonia. It typically comes in a white or a brown powder. After a history of long-term use, withdrawal symptoms can begin within hours of the last use. When given by injection into a vein, heroin has 2 to 3 times the effect as a similar dose of morphine. Most people say that they are addicted after their first high. Heroin was first made by C.R. Alder Wright in 1874 from morphine, a natural product of the opium poppy. In 2015, Afghanistan produced about 66% of the world's opium. In the early 2000s, most patients that overdose did so intentionally by using pills. Currently, the majority of patients who overdose are doing so with heroin, and it is accidental. Between 2015 and 2016, there was a 19.5% increase in heroin-related deaths. Males ages 25 to 44 were amongst the highest group affected. Killer heroin arrived on the scene. This is heroin laced with fentanyl. Fentanyl was discovered in 1959. It is a highly addictive synthetic alternative to morphine. It was used to treat pain in the terminally ill. In the 1980s, a few underground chemists altered the chemical makeup of fentanyl to make it a highly toxic and potentially lethal drug called China White. When you mix fentanyl with heroin, it amplifies the potency of both drugs. Once injected, smoked, or snorted, killer heroin creates a powerful high, and many victims are still found with a needle in their arm. Most users have no idea that their heroin is laced with fentanyl, and death can occur within minutes after injecting killer heroin. Very few are lucky enough to receive the antidote, naloxone, which is more commonly known as Narcan. Hopefully they receive this in time to survive their killer high, but many addicts are carrying their own Narcan these days. Drug dealers have been known to give out samples of this heroin. Once the word hits the streets that there has been a string of fatal overdoses, the dealers see an increase in sales. It's basically free advertising. Those that are addicted are attracted to this because they can never get high enough. The overall national outlook is grim, and it is particularly bad in some states. 22 states and the District of Columbia had overdose rates significantly higher than the national average. Heroin is everywhere, big cities, small rural towns. Really, there is no area that is exempt. A few really interesting facts from the CDC for 2016 data. 116 people died every day from opioid-related drug overdose. 11.5 million people misused prescription opioids. 170,000 people used heroin for the first time. And it cost $504 billion to our economy. Across the United States, the number of donors had a small but steady increase year after year since 2010. In 2014, it started to pick up, but the largest increase was seen from 2015 to 2016. This was the highest increase in any year in our history. The number of overdose death donors nearly doubled in 2016. The percentage increase in overdose death donors from 2015 to 16 was 49%. What do most people visualize when they hear New Jersey? Many of you may have flown into Newark Airport and didn't see a very pretty picture, which is the one on the bottom in the middle. Some of you may have followed The Sopranos. Upper left-hand corner, does the Bada Bing look familiar to you? How about the Jersey Shore? Do any of the fans recognize their shore house on the top right? And I just want everyone to know that only one member from the original cast was actually from New Jersey. They don't call it the Garden State for nothing. The truth is, New Jersey has many rural areas, beautiful beaches, and tasty produce. The majority of our overdose deaths are not from the inner cities. They are spread out all over the state. The worst hit counties in New Jersey are Atlantic, Ocean, and Essex counties. In 2016, our percentage of overdose death donors rose to 22% of our overall donors. This was a staggering 144% increase. Again, you can see the biggest increase was from 2015 to 2016. In 2016, we had 38 overdose death donors with 134 organs transplanted, and 43 donors in 2017 with 124 organs transplanted. In 2016, our organs transplanted per donor for this group was 3.53, but it significantly dropped in 2017. There were two contributing factors to the decline. One was a less healthy donor pool in 2017 compared to 2016, and an increase in positive serologies in 2017, which I will address further. What role does increased risk play? In 2013, the U.S. Public Health Service revised the 1994 CDC high-risk guidelines, which were criteria that only addressed behavioral risk factors for HIV. The updated guidelines included behavioral risk factors that would put someone at increased risk for disease transmission of HIV, hepatitis B, and hepatitis C. In 2014, UNOS required additional items that would classify a donor as increased risk. I'm going to go through each one of these risk factors, and then we're going to do a few scenarios. The 2013 PHS increased risk guidelines cover anything that happened in the previous 12 months. Any person that had sex with a person known or suspected to have HIV, hepatitis B, or hepatitis C infection, men who have had sex with men, women who have had sex with a man with a history of male sex, male behavior, sex in exchange for money or drugs, sex with a person who had sex in exchange for money or drugs, a person who had injected drugs by IV, IM, or sub-Q route for non-medical reasons, sex with a person who injected drugs by IV, IM, or sub-Q route for non-medical reasons, a child who is less than or equal to 18 months of age and born to a mother known to be infected with or at increased risk for HIV, hepatitis B, or hepatitis C infection, a child who has been breastfed and the mother is known to be infected with or at increased risk for HIV infection, lockup, jail, prison, or a juvenile correctional facility for more than 72 consecutive hours, and newly diagnosed with or have been treated for syphilis, gonorrhea, chlamydia, or genital ulcers. In addition, the additional UNOS items are any donor that does not have a DRE or medical social history, a hemodiluted specimen for serologies, and a person who received hemodialysis even once in the previous 12 months, which puts that donor at increased risk for hepatitis C only. Having positive serologies alone does not meet the criteria for increased risk. This is considered to be a known risk or a presumed infection. Increased risk designation is stating that the donor has engaged in behavioral risk factors that place them at higher than average risk for recent acquisition of HIV, hepatitis B, and hepatitis C. Non-prescription opioids can be used via multiple routes: ingestion, injection, smoking, snorting, and even suppository. Knowing the route used does make a difference because only injection will classify the donor as increased risk. As you can see from this table, that not all overdose death donors are increased risk, and they are not also all related to IV drug abuse. I want to review a few scenarios with you. A patient that overdosed on prescription meds and does not meet any of the behavioral risk factors would not be classified as increased risk and fall into the blue group. A patient that snorted heroin and does not meet any of the behavioral risk factors would not be classified as increased risk and would also fall into this group. A patient that overdosed on heroin but only snorted it and was in jail for 72 hours in the previous 12 months for non-payment of child support would classify as an increased risk and fall into the orange group. But it's not because of the heroin. It's only because he met the behavioral risk factor for the jail time. This is why knowing the route is super important. A patient that overdoses on heroin by injection automatically places them in the increased risk category. They would actually fall into the orange and the gray categories. Even though the number of donors increased each year, the percentages of each of these categories basically remain unchanged. One of the most common questions that I have been asked over the last few years is, can someone who overdoses on heroin still be an organ donor? The answer is yes. Generally, if the person was otherwise healthy, the opioids would have little to no effect on the outcome of the organs when transplanted. If we were to plot out all of our deceased donors and their organ outcomes, they would follow the same pattern as we see here with all of our overdose death donors. We even had one split liver donor in 2016 from this group. Positive serologies. This is really where the biggest problem lies. On every donor, we are required to run HIV, hepatitis B core, and hepatitis C antibody and NAT testing. NAT stands for nucleic acid testing. This is a highly sensitive method of testing blood for these diseases. Most traditional screening tests require the presence of antibodies to trigger a positive test reaction. The period of time between initial infection and detection of antibodies is called the window period. NAT reduces the window period by detecting low levels of viral genetic materials that are present soon after infection, but before the body has had a chance to start producing antibodies. We had a 100% increase in overdose death donors with positive serologies in 2017 from 2016. Even though we had such a drastic increase in overdose death donors with positive serologies in 2017, we were able to place more organs for transplant from these donors than we did in 2015 and 16, including 4 hearts and 2 lungs. While our organs transplanted per donor fell in 2017, our observed versus expected ratio remained steady, indicating that we just had a less healthy donor pool in 2017. When you add on the layer of positive serologies onto an overdose death donor, the potential drastically decreases. In 2016, our potential in this group decreased by 80%. Let's compare overdose death donors with negative serologies to overdose death donors with positive serologies. It is clear that the presence of positive serologies in the overdose death donors, our organs transplanted per donor, significantly decreases. I do believe that the research that is being done with transplanting hepatitis C positive organs into hepatitis C negative recipients with early positive data, as well as medications that are available that can cure hepatitis C, are part of the reason we are seeing an increase over the last 3 years in the group with the positive serologies. However, we still have a long way to go to catch up to the negative serology group. When I was looking through the data, there were 3 really interesting cases that stood out and I wanted to present to you. The first case is a 38-year-old female, 5 foot 4 inches, 66 kilograms, with a BMI of 25. Blood type of O. She was positive IV drug abuser and positive increased risk behavior. Her serologies were positive for hepatitis C antibody and hepatitis C NAT. There were only 14 recipients on the heart list. Her heart was transplanted at TNVU. There were only 51 recipients on the lung list, and her lungs were both transplanted at MAPB. There were 737 recipients on the liver list, and her liver was transplanted at PATJ, and only 62 recipients listed on the kidney list. Her kidneys were transplanted at PAHM and NYCP. To transplant 6 organs in the presence of IVDA, increased risk, and positive serologies from one donor is extraordinary. There was nothing that was specific on this case that stood out to indicate why we were able to have so many organs transplanted for this patient. when I compared it to other similar donors with similar age and criteria. I think this case is definitely an outlier. The second case is a 25-year-old male, 6 foot 2 inches, 85 kilograms, with a BMI of 24. Blood type is O. He was a positive IV drug abuser, positive for increased risk behavior. Serologies were only positive for hepatitis C NAT. There were only 20 recipients on the heart list. His heart was transplanted at PAUP. This was the first heart that PAUP transplanted in their THINKER study, in which a heart from a hepatitis C positive donor was transplanted into a hepatitis C negative recipient. The recipient was monitored for a rise in specific blood markers for hepatitis C. Once they hit a certain level, the recipient was treated with the hepatitis C meds and has since tested negative for hepatitis C, and he is doing very well as of the last report. This patient's liver was also transplanted at NYWC, and there were 831 recipients on the list. Unfortunately, we were not able to transplant the kidneys. The terminal creatinine was 4.56. There were only 48 recipients on this list. It is not the best terminal creatinine, but we have definitely seen kidneys with a higher creatinine be transplanted. I wonder if the serologies were negative. There may have been a kidney center that would have taken a chance to transplant these kidneys, or if the recipients were willing to take the organ and then be treated for hepatitis C if they converted. That is definitely our hope for the future. And the last case is a 16-year-old female, 5 foot 7 inches, 68 kilograms, with a BMI of 23. Blood type is A non-1. She was a positive IV drug user and positive for increased risk behaviors. Her serologies were negative. There were 267 recipients for the long list, and they were transplanted at PAUP. 7,504 recipients on the liver list. This was a split liver. The larger segment was transplanted at PAHE, and the smaller segment at PACP into a child. There were 15,015 recipients on the kidney list. Both kidneys were transplanted at St. Barnabas here in New Jersey. Did you notice how many more patients are listed when IVDA, increased risk behavior, overdose death donor, has negative serologies, over the much smaller list when the serologies were positive? This donor really stood out for me, since we usually have 1 to 2 split livers per year, and in 2016, one of them was from an IVDA, increased risk behavior, overdose dose donor. And my last fact. It seemed to me that many of our overdose death donors were designated as first person, so I decided to pull the data. 55% of our overdose death donors in 2016 were first person designation. This is really impressive, since only 33% of adults in New Jersey are registered in the motor vehicle registry. New Jersey is among the bottom 5 states in the country for state registries. And on average, 38% of our yearly donors are first person designation. Thank you, everyone, for your time, and I'd like to turn it over at this time to Dr. Samantha Atchison.
Thanks, Sharon. Good afternoon, everybody. I'm going to switch the focus of this webinar now to the organ transplantation side of the opioid epidemic. So we heard from Sharon about how clearly there are more overdose deaths since the opioid epidemic has increased. But does that mean that there's really a correlation with more organ donors nationwide? So before I get into this slide, I would like to thank Dr. Sam Wyndham at the University of Alabama in Birmingham. He's a friend, and he graciously shared an abstract that he and his group will be presenting at ATC this year in a plenary session. So what they did is they analyzed the data from the OPTN database, looking at deceased organ donors whose mechanism of death was reported as a drug overdose, and who had at least one organ transplanted from the time period between January 2000 and December 2016. So as you can see in this figure, the trends in the mechanism of death for organ donors has changed over this time period. The most significant change is the increase in donors after drug intoxication, which you can see in the light blue on the bottom. In 2000, the rate was 1.1%, and by 2016, it increased to a staggering 12.7%. The only other cause of death that had a large increase, while the others remained fairly stable, were deaths from cardiovascular disease. Causes of donor death vary across the 11 OPTN regions. And when you look at overdose deaths, you can see that the nationwide average for all regions, which is that first column there, is 9.3%. If you look at the light blue sections at the bottom of the slide, on the bottom of each of the bars, you can see that the lowest is Region 4, which is Texas and Oklahoma. They have the lowest rate at 3.6%, while the Northeast has the highest rate of overdose deaths at 18.1%. This map looks at the age-adjusted mortality rates per 100,000 population for drug overdoses in 2015. Now, these aren't donors. These are just reported overdose deaths. And you can see that the Northeast and the Western U.S., the areas that have the darkest shaded areas, those are the regions with the highest mortality rates for overdoses. And this map breaks up the 11 OPTN regions so that you can easily compare which ones have the highest rates. This map represents the proportion of drug intoxication deaths that occurred in a medical facility per state. The lowest was in Maine at 12.6%, while the highest was 44.1% in Massachusetts. And again, this map delineates the OPTN regions. The corresponding percentages that you see show the proportion of all drug intoxication deaths from CDC data that resulted in organ donation, which is from OPTN data. So we know that the organ donation deaths from overdoses is increasing, and this is at an alarming rate. However, what you see is that the regions with the highest percentage of overdose deaths, we're not seeing a correlation with these deaths converting into actual organ donors. And this is staggering, I think. If you look, despite 28.2% of drug overdose deaths that occur in healthcare facilities in 2015, only 1.62% actually became organ donors. And you see in Region 8, 2.36% became organ donors, and they have one of the lowest mortality rates from overdose deaths. So to answer the question of are we underutilizing this potential donor pool, it seems based on that data that we are. Last year, the New England Organ Bank, which is now New England Donor Services, published their data showing how they were dealing with the rising opioid epidemic. They recognized the need to maximize organ transplantation and take this tragedy and use it as an opportunity to safely benefit potential recipients. So they did this with a four-part strategy to handle the increased risk donors. First, they implemented the updated PHS guidelines, which Sharon described earlier, and they performed NAT or nucleic acid testing on all of their donors routinely. So as we all know, NAT testing reduces the window between exposure to and the detection of HIV, Hep C, and Hep B to less than a week. They also conveyed all donor information to each of their transplant centers, which in turn gets communicated to potential recipients. And this is a key part of the informed consent process. It's also one of their regulatory and policy requirements. In addition, the transplant programs that are serviced by that OPO participate in current treatment strategies if a recipient contracts a donor-derived infection. So for example, current HIV management and potential curative hepatitis C therapy. The results of their experience from 2012 to 2016 show a huge increase in donors from drug overdoses, as well as a 300% increase in organ transplants from hepatitis C positive donors to hepatitis C positive recipients. With more than 11,000 transplants from increased donors, they had 2 cases only of unintentional hepatitis C transmission. Both of these came from increased risk donors with a history of drug abuse and overdose at the time of death. One was oral opioid overdose, and the other was IV drug abuse found with a needle at the time of death. But you can see that by formalizing their strategy, they help to avoid potentially discarding these life-saving organs. Clearly, there are barriers to using these increased risk organs. Otherwise, we wouldn't be talking about this today, and we wouldn't have the problem of underutilization of these organs. The risk of transmission of disease is probably the biggest concern. At least that's what I hear from my patients the most. And in addition, I think that there really is a stigma of the PHS increased risk designation that patients feel, and I think that this is a very real concern. It's a common question to ask, well, which recipients are appropriate for PHS increased risk organs? Some people believe that the potential infectious risk would be outweighed by the benefit of transplantation overall. In 2013, Chow and his group from Johns Hopkins University created a decision process model to estimate the survival of accepting an increased risk donor versus declining that offer and then continuing to wait for a non-increased risk donor offer. This model allows patients, and providers as well, to look at the recipient's particular phenotype. So they use multiple factors: age, gender, BMI, ABO, race, PRA, the cause of their renal failure, whether or not they've had a previous transplant, how long they've been on dialysis, and how long it would be to wait for the next standard risk donor. And they have a model that you can look at online and put in all of this information. This is a screenshot of what the tool looks like. And their study used the data from the SRTR database and created estimates on survival that are made based on a combination of observational data in transplant patients, as well as best estimates from the literature based on other non-transplant populations. The goal of this was to develop the model and identify which patient characteristics are most predictive of the outcomes of their decision as to whether or not to decline or accept a particular offer. The model looks at different scenarios and can show graphically over a 5-year period what the estimated survival would be for that patient. Based on their model, estimated survival differences at 5 years attributable to accepting an increased risk donor kidney using different patient phenotypes actually is quite varied, as you can see. But more importantly, they identified recipient factors that had the greatest impact on the survival difference. They also identified a tipping point that could be calculated based on the offer and the recipient factors. And the tipping points considered the time that a patient would be expected to wait for a non-increased risk donor transplant, beyond which accepting an increased risk kidney would give a 5% or higher survival difference. Now, this is only a simulation model, but it can be an important tool when patients are considering weighing the risks and benefits of an increased risk donor organ versus holding out to wait for a non-increased risk donor offer. Educating each other and our potential recipients really is critical, especially because disease transmission is generally what most people worry about when it comes to increased risk donors. When you look at unintentional transmission of hepatitis C in a donor that has negative serologies and negative NAT testing, the average risk of transmission of hepatitis C for an increased risk donor is extremely low. It's also quite low if the donor doesn't have any behavior to warrant the PHS increased risk behavior category. The largest risk comes from those PHS increased risk donors with a history of IV drug abuse, and even that risk is 0.003%, which is still exceedingly low. The risk of dying on the wait list far exceeds the potential risk of disease transmission with accepting an increased risk donor organ. Therefore, the theoretical risk of contracting a disease from a transplant is not well supported by the data, and this information really needs to be shared with our patients. In addition, even if the donor has hepatitis C and this is missed, there's no guarantee that the donors actually will have the virus transmitted, and this also highlights the importance of post-transplant surveillance. Although there have been some small series that show outcomes with increased risk donors and overdose deaf donor organ transplants, I wanted to highlight 2 papers that talk about large patient populations that show what's going on in our nationwide transplant community. The first is a retrospective study out of Rush University in Chicago where they looked at the OPTN database to examine post-transplant outcomes in liver recipients of increased risk donor organs. Over 58,000 liver transplants were performed between 2004 and 2013, and 9.4% of these were PHS increased risk donor organs. Initially, when they did the unadjusted analysis, mortality and graft failure were actually lower in the increased risk donor group. However, when they controlled for recipient and donor characteristics, there wasn't a significant difference between the 2 groups. Instead, what they found is that donor hypertension, cold ischemic time, and MELD were independent predictors for graft failure on multivariate analysis and also for mortality. Recipient hypertension, diabetes, and COPD were mortality risk factors, while diabetes and female gender predicted an increased risk of graft failure. So I think this is a really important study showing that increased risk donor organs have non-inferior outcomes when it comes to liver transplantation. The next few slides are from a paper that was just published this past Tuesday in Annals of Internal Medicine looking at outcomes in liver, kidney, heart, and lung transplants with overdose death donor organs. And I really would like to thank Dr. Christine Duran from Johns Hopkins University for her important work on this and for sharing this paper with me ahead of time so that I could use it today for this webinar. So thank you very much. Their group used SRTR data and compared outcomes from organs from overdose death donors with trauma and medical death donors. They looked at over 7,000 overdose death donors that they identified, and that resulted in nearly 20,000 transplants across different organ systems. The mechanism of death for the donors was designated as drug intoxication, although there was no differentiation between opioid and non-opioid overdose. So in 2000, like I mentioned earlier, overdose deaths accounted for 1.1% of donors. In 2017, 13.4% of donors. The trend since 2000 has been a steady increase in overdose deaths, as we've been talking about, and a subsequent increase in transplants using organs from overdose death donors. The graph on the left is the age-adjusted overdose death rates per 100,000, which is represented by the dotted black line. And the number of overdose death donors recovered between 2000 and 2016 is represented by the red line. From the graph, it's really easy to see that the accelerated rise, particularly of overdose death donors over the last few years. In the second figure, you can see the number of transplants increase annually across all organs using these donors. These were across 274 programs in the United States, and during the study, the median overdose donor death transplant number increased from 2 per program in 2000 up to 10 per program in 2016. The maps at the top of the slide show the progression from 2000 to 2016 with regard to overdose deaths in the donor pool at the state level. In 2000, overdose death donors did not account for any donors in 15 states, but in 2016, overdose death donors accounted for more than 10% of donors in 29 states. And you can see the states with the darker colors have the highest percent of overdose death donors. So again, a lot of the focus is on the Northeast. Massachusetts, New Hampshire, New Jersey, New York, and Maryland each had more than 20%. The bottom maps represent the CDC age-adjusted state overdose death rates. In 2000, only 6 states had reported rates greater than 10 per 100,000 overdose deaths. And those are the darker shaded states, New Mexico, Nevada, and DC. North Dakota data wasn't available, so that's why it's beige. Now in 2016, 48 states and District of Columbia reported rates greater than 10 per 100,000 of overdose deaths. And the highest is the darkest state, West Virginia, at 52 per 100,000. Ohio, New Hampshire, DC, and Pennsylvania all came in between 35 and 40 per 100,000. And these numbers really are staggering and somewhat disturbing. As mentioned earlier from the UAB abstract, you can see that there's clearly a discordance of where the overdose deaths are highest versus where the number of overdose death donors are highest. It's important to ask who are these donors and what do they look like. So this table compares the characteristics of overdose death donors with donors who die from trauma or those from a medical death. Now, overdose death donors are found more commonly in the Northeast and Midwest. They're younger, aged 21 to 40 mostly, and white at 85%. And we may tend to think of these donors as young and healthy. That's what we always tell people, oh, they're younger, healthier donors. However, when you compare them to trauma death donors, who we also think are typically young and healthy donors, overdose death donors do have a higher incidence of hypertension, diabetes, and previous heart attack. When you compare them to medical death donors, though, they're less likely to have hypertension, diabetes, or previous MI. Also, overdose death donors tend to be more likely to be DCD donors, or donation after cardiac death, and they also tend to have a higher terminal creatinine when you compare them to the other 2 sets. Perhaps not surprisingly, overdose death donors also had a higher percentage who were hepatitis C positive at 18.3% compared to 3.2% of trauma death donors and 4.1% of medical death donors. They were also more likely to be labeled PHS, increased risk, at 56.4% when you compare them with other mechanisms of death. Looking at hepatitis C positive donors over the time period of the study in a different format, you can see that the rate is higher for overdose death donors. What's interesting, I think, in this slide is that the rate over the last 16 years is fairly consistent for trauma and medical death donors, while clearly there's an increase in overdose death donors that's illustrated by the dotted red line, with a particularly large increase in the last 5 years. Overall, there's been an increase in the number of donors since the PHS increased risk designation came about. However, with overdose death donors, that number has clearly risen at a higher rate compared with trauma and medical death donors. In 2005, 31.4% of overdose death donors were designated as increased infectious risk, but in 2016, that number was 71.8% of donors that carried the designation. Durand and colleagues looked at 5-year patient survival for kidney, liver, heart, and lung recipients and compared overdose death donors with trauma death and medical death donors. For kidneys, after standardization, 5-year patient survival was 83.1%, with a standardized risk difference at 5 years of negative 3.1%. A negative standardized risk difference means lower survival, while a positive risk difference means increased survival. And looking at these results for heart and lung, the standardized patient survival is slightly higher for overdose death donors compared to trauma and medical death donors. For kidney and liver, the standardized survival is lower for overdose death donors compared with trauma death donors, but it's higher than it is for medical death donors. When you look at death-censored graft survival as opposed to patient survival, the graft survival was similar or higher for kidney, heart, and lung recipients when you look at the standardized risk difference at 5 years for overdose death donors versus trauma or medical death donors. However, with regard to livers, the standardized 5-year graft survival was lower for overdose death donors when compared to trauma death donors, and similar for medical death donors. Noting that the outcomes are similar for patient and graft survival, and at a minimum, not inferior, it's really interesting to look at the discard rates of organs based on the mechanism of donor death. Discarded organs are those that were recovered but ultimately not transplanted. And after standardization, discard of overdose death donor kidneys remained higher than trauma death donor kidneys, but after additional standardization, they found a lower percent were discarded compared to medical death donors. Discard rates were similar between overdose and trauma death donors for hearts and lungs, and between overdose death and medical death donors for livers, hearts, and lungs. So despite these overdose donor organs having favorable characteristics, livers and kidneys still tended to be discarded at a higher rate. This is likely due to the PHS increased risk designation and also the higher prevalence of hepatitis C infection. Again, this shows that we're not utilizing this donor pool to the fullest extent, despite the consistent disparity that we have between those that actually need organs and the available donor pool. Just to give a brief look at what we're doing over in New Jersey, at St. Barnabas Medical Center, we decided to look at our data and see whether or not we were along the same lines as the national data. So we pulled the data from the last 2 years to look at our increased risk use. In 2016, 11.8% of the renal transplants were with increased risk donor organs, and 4 hepatitis C positive organs were used and transplanted into 4 hepatitis C positive recipients. In 2017, 13.7% of our kidneys were from increased risk donors with only 1 hepatitis C transplant. The DGF rate was similar to our center's average for both years, and we so far have had no graft losses or patient deaths with any relation to these increased risk donor allografts. Sharon discussed what we do from an OPO standpoint here in New Jersey. And at our center at St. Barnabas, we discuss PHS increased risk donors routinely at the time of the initial evaluation process. Patients, when they come in, are required to sign a consent form if they're willing to consider these increased risk offers. The advantage to them is that if they're willing to accept these offers, they may be able to receive a transplant sooner than the typical wait time, which is approximately 5 to 7 years in the state of New Jersey, because other patients who are not willing to consider these offers would be bypassed on the list. Patients then get flagged in our database when they're listed and made active, so as to whether or not they're willing to consider these offers. And this does make it somewhat easier for our coordinators to navigate who to call. In addition, it also avoids having a potentially challenging phone call and introducing this concept of increased risk donors at 2 o'clock in the morning with a patient or patient's family members. Overall, I think based on the data available, the opioid epidemic has created a large, very underutilized donor pool, and it's imperative that we continue to educate each other and especially our potential recipients. I particularly want to thank those who are doing research in this field and showing that at a minimum these organs do not have inferior outcomes and that we can safely transplant many of our patients with them. In the future, I think that we will hopefully maximize the utilization of hepatitis C positive organs safely as we continue with more research. Thank you.
Thank you very much, ladies, for such an insightful presentation. Before I turn it back to Andrea for questions, just as a reminder for everyone, if you do have questions for either of our presenters, please submit them using the chat feature in the bottom left-hand corner of the screen. While we're waiting on those questions to roll in, I'd also like to take the opportunity to remind you that the Alliance Transplant Resource Guide and Tools is one of our valuable signature offerings. It's a free roadmap for developing and sustaining high-quality, patient-centered excellence in donation and transplantation. It offers strategies and change concepts, actions, and a host of resources that will enhance the transplant program operations. It's a completely free resource, and it's available to you on our website at organdonationalliance.org/resources. Now, during the Q&A time, I will have this poll up. For those of you who are listening in a group, if you'll please complete this poll and let us know how many people were listening in your group, that would be very helpful for us. So at this point, I will turn it back to Andrea to moderate our questions.
Thank you, Corey. I'm just looking to see the questions here. So Sharon, can you tell us a little bit about what your action plan is at the Sharing Network?
So as I mentioned, we did have already one heart transplanted into a non-Hep C negative recipient. So we do participate with the Thinker study to do that for kidneys as well as hearts when those patients are listed.
Thank you very much. And Dr. Atchison, do you think that the work that we're seeing published most recently is going to have an impact on using more of these donors going forward?
I do think so. I think that the work that we've seen lately is very important, and I think that it will help patients. I think if the data is presented properly to patients, then I think that will help decrease some of their reluctance to accept them. And more importantly, surgeons and medical physicians who hopefully will reconsider if they're not accepting these offers at this time.
Thank you. We do have a question, actually. So the first question is, to what degree of detail do your coordinators or physicians go into detail educating recipients about PHS, specifically IVDA, and what role do your coordinators play in this education? I can also help to answer that from St. Barnabas Medical Center. We initially started having our coordinators provide that education, but we have switched to having our physicians do that. And our coordinators are really ensuring that there is documentation that each physician had the discussion and that it's documented or evidenced in the history and physical of the patient. Do you want to add to that, Dr. Atchison?
I think also doing a surgical evaluation, and we don't necessarily see every patient here, but there are certain patient populations where you bring this up again, and it never hurts to keep having the discussion with patients because two physicians can present the same information in a different way, and it can enlighten a patient differently, whereas they may be more willing to consider or accept these offers.
Thank you. We have another question, and the next question is, have you had any problems with payers being willing to cover Hep C positive organ going into Hep C negative recipients?
I don't think we haven't done any here Hep C positive donors into Hep C negative recipients.
So at PAUP, I know that they're doing that through a research trial right now, so that's still in the research phase, so I think it's being covered through that. They must have a grant for that to cover it, but it's not in the regular system.
Yeah, as far as I know, those are only being done under research protocols now.
Thank you. Are there any other questions? Please feel free to answer them. Right now, there are no more questions, Corey. I don't know if you want to give people a few more minutes to type in.
Sure. We'll give just a couple of more minutes for individuals to post their questions. Remember that none of the questions will be able to be posed verbally, so we do need you to submit those questions using the chat feature in the lower left-hand corner. We'll allow just a few more seconds for some questions to roll in. But in the meantime, I wanted to extend our sincere thanks once again to Sharon and to Dr. Atchison, as well as to you, Andrea, for your time and for an outstanding presentation today. And if there are no more questions, I believe we can go ahead and conclude. To all of our participants, we want to thank you for your time, and we look forward to seeing many of you next week at Austin for the Transplant Management Forum. Thanks so much, and have a wonderful rest of your day. Take care.